Today, we will discuss our approach to dysphagia, a high-yield topic on your NBME and USMLE exam. So at the end of this talk, you should be comfortable answering the following questions. What are the two types of dysphagia, causes of dysphagia, the signs and symptoms associated with dysphagia, what are the diagnostic testing for each type of dysphagia, and what are the primary management of dysphagia. But first, let's define dysphagia. So dysphagia is a common condition that disrupts the swallowing mechanism, causing a difficulty in food passing from the mouth to the stomach. There are two types of dysphagia, oropharyngeal dysphagia and esophageal dysphagia. It is also important to understand that dysphagia is difficulty in swallowing compared to odynophagia, which is pain caused by swallowing. It is important to identify patients with dysphagia because they are at high risk of aspiration. In order to identify that the clinical vignette is related to dysphagia, let's discuss the important buzzwords to remember, such as history of coughing or choking while eating, nasal regurgitation, halitosis, and sensation of food getting stuck. For example, here is a 50-year-old patient who reports regurgitating undigested food soon after eating solid food, and occasional coughing and choking after swallowing. He reports no weight loss, no chest pain. On physical examination, vital signs are normal. BMI is 26, and the remainder of the examination is unremarkable. In this case, we know that the patient has dysphagia since he reports regurgitating undigested food and coughing and choking after swallowing. So let's first discuss the first type of dysphagia, and this is called oropharyngeal dysphagia. It is also called transfer dysphagia. This occurs when the patient has difficulty transferring food from the mouth to the upper esophagus. Common symptoms include choking, coughing, nasal regurgitation of food, and even hoarseness. When considering etiologies related to oropharyngeal dysphagia, consider pathologies that are above the upper esophageal sphincter. So the easiest way to remember the causes of oropharyngeal dysphagia, it's easier to break them down into two categories. Break them down into neuromuscular causes and structural causes. So what are your neuromuscular causes? The most common is either stroke or advanced dementia, but patients with Parkinson's disease, ALS, muscular dystrophies, and even myasthenia gravis is related to oropharyngeal dysphagia. And as far as structural causes, the most commonly asked questions are related to Zenker's diverticulum, radiation injury, and oropharyngeal cancers, as well as any bars and webs related to the upper esophagus. So let's go back to case number 1. As you remember, this is a 50-year-old male. He has difficulty moving food from the mouth to the esophagus. We now know that he has a diagnosis of oropharyngeal dysphagia based on the clinical manifestation. But how do we confirm this diagnosis? What is the intervention that we need to order to confirm that this patient has oropharyngeal dysphagia? So if the patient presents with clinical findings related to oropharyngeal dysphagia, the next best step really is to order a modified barium swallow. Keep in mind that it is also called a video fluoroscopic swallow study. So in your exam, they could either give you a modified barium swallow or a video fluoroscopic swallow study as one of the answer choices. So this is a radiographic procedure. It's designed to define the anatomy of the oral cavity, the pharynx, and the cervical esophagus, as well as the physiology of the patient's oropharyngeal swallow. It is the standard imaging modality if you're trying to diagnose someone with oropharyngeal dysphagia. It is also very useful in identifying aspiration risk in patients with oropharyngeal dysphagia. In this lateral graph that you see on the right-hand side, the arrow shows a nasal regurgitation of a food bolus with consistency of a liquid into the nasopharynx, which is abnormal. All right, let's discuss another case. So this is a 60-year-old male. He is complaining of bad breath and recurrent coughing spells. We know he has oropharyngeal dysphagia based on the keywords we have discussed earlier, and therefore we ordered a modified barium swallow. and it shows an outpouching on the lower part of the pharynx as shown on the right-hand side. What do you think is the diagnosis? This is Zenker's diverticulum, a commonly asked question on your exam and therefore a very high-yield topic to remember. So the primary goals of managing oropharyngeal dysphagia are two: improve food transfer and prevent aspiration. The approach really depends on what's causing the dysphagia. So if the patient has oropharyngeal dysphagia related to a stroke or even a degenerative neurologic disease, then we likely would proceed with swallow rehabilitation in order to facilitate oral intake. If the patient has primary cricopharyngeal dysfunction, then an endoscopic or open myotomy is recommended. Now, if the patient presents with esophageal webs or esophageal strictures, then what is recommended is an endoscopic dilatation. There are certain situations that patients have more of a higher risk of aspiration, and this is more related to patients with a significant stroke. And in this situation, we recommend a feeding tube to reduce their risk of aspiration. Now that we have discussed the first type of dysphagia, let's discuss the second type, which is called esophageal dysphagia. It is also called transport dysphagia. The etiologies are pathology below the upper esophageal sphincter, and it occurs usually when there is a discomfort in the mid to lower sternum as the food bolus moves through the esophagus. So the causes of esophageal dysphagia can be organized into three different types: structural abnormality, infection or inflammation, and motility disorder. Structural abnormality includes strictures, esophageal web or ring, or malignancy. Infection or inflammation includes eosinophilic esophagitis and pill esophagitis. And motility disorder includes achalasia, esophageal spasms, and scleroderma. Esophageal stricture presents with dysphagia to solids and rarely to liquids with progressive symptoms. It is associated with history of GERD, especially those who refuses to see any primary care doctors or GI doctors and never been on treatment for PPIs, as well as those with peptic ulcer disease and those patients with a history of radiation therapy. So peptic stricture is a complication of GERD. It is commonly associated in conditions associated with increased esophageal acid exposures, and this includes Zollinger-Ellison syndrome, systemic sclerosis, and nasogastric tube placement. The barium swallow would show evidence of strictures. However, to confirm the diagnosis, the next best step really is an upper endoscopy. So esophageal ring is associated with intermittent dysphagia to both solids and liquids. So the buzzword in your exam is intermittent dysphagia, and it's related to solids and liquids. It is diagnosed either on a barium esophagram or a upper endoscopy. It appears as a focal thick constriction of variable luminal diameter. It looks like a ring, especially when you do an upper endoscopy, as seen on the left-hand side. What's commonly asked in your board exams is the syndrome called Plummer-Vinson syndrome, and this is a classic triad of dysphagia, esophageal rings, and iron deficiency anemia. So which of the following medications is least likely to cause pill-induced esophagitis? Is it doxycycline, tetracycline, NSAIDs, levothyroxine, ferrous sulfate, or potassium chloride? The least likely is levothyroxine, since in pill-induced esophagitis, it's been strongly associated, and now a high yield for your exam are medications such as doxycycline, NSAIDs, ferrous sulfates, tetracyclines, and potassium chloride. So usually the patients commonly reports dysphagia or even odynophagia, which is pain with swallowing. And the right answer, if they're asking for any strategies or management, is to reduce esophageal injury, and this includes drinking sufficient amount of water when taking the medication and also remaining upright for at least 30 minutes after pill ingestion. So the evaluation of esophageal dysphagia includes the following: an upper endoscopy, a barium swallow, and a high-resolution esophageal manometry. So the barium swallow is also called a barium esophagram or esophagram, or even classic barium swallow, which is different from modified barium swallow when we were talking about oropharyngeal dysphagia. So please remember these important names associated with each intervention. So a barium swallow is a contrast-enhanced radiographic study. It commonly uses to assess the structural characteristics of the entire esophagus. And a high-resolution esophageal manometry is the diagnostic tool that we use currently to evaluate for esophageal motility issues. So now let's discuss a case of a 30-year-old male who reports a sensation of solid food sticking over the chest area several times a week. An upper endoscopy was done, and a biopsy showed more than 15 eosinophils per high power field. What do you think is the likely diagnosis? So the likely diagnosis is eosinophilic esophagitis. The patient reports solid food dysphagia, so an upper endoscopy was performed. Keep in mind that this is one of the most prevalent causes of dysphagia and therefore a high yield on your board exams. This is a clinical histologic diagnosis, so not only does the patient have to present with dysphagia, a biopsy is required, and the biopsy result has to show at least 15 eosinophils per high power field. It often co-occurs in patients with food allergies, asthma, and eczema. And what is usually seen on upper endoscopy are rings and furrows in the esophagus, as seen on the image to your right. So what do you think is going on in this case? This is a 50-year-old male patient. He presents with progressive dysphagia to both solid food and liquids. He has history of heart failure with a reduced ejection fraction of less than 30%, with an NYHA class 2 symptoms. An upper endoscopy was performed and did not reveal any mass. And here is the barium esophagram. What do you think is the diagnosis? This patient likely has achalasia. The common presentation for achalasia includes dysphagia to both solids and liquids. It is a motility disorder of the esophagus, resulting in aperistalsis and inadequate relaxation of the LES. The initial diagnostic test is really a barium esophagram, and it shows a dilation of the esophagus with narrowing of the gastroesophageal junction known as a bird's beak sign, as shown in the right image. When you do an upper endoscopy, it will not show any signs of mechanical obstruction or mass, but it does show a tightness at the gastroesophageal junction when you advance the scope into the esophagus towards the stomach. So the primary goal in treating achalasia is to lower the LES pressure to relieve the patient's symptoms. Endoscopic therapy involves injecting Botox, or pneumatic dilation, or performing an endoscopic myotomy. Medical therapy is only recommended to patients who are poor candidates for an endoscopic or surgical intervention, and therefore medical therapy is third-line therapy. Calcium channel blockers such as nifedipine or long-acting nitrates are known medications that can lower LES pressure. So let's go back to that case. He is a 50-year-old male with achalasia. He has a history of heart failure with reduced ejection fraction of less than 30%, but he is very symptomatic. What do you think is the most appropriate treatment? You ask yourself, is he even a good candidate for surgical intervention such as myotomy? The answer is no. Since this patient has a high surgical risk, the next best step really is an endoscopic botulinum toxin injection before we even consider medical therapy like nifedipine. So this condition commonly presents with chest pain or dysphagia. On the esophagram, there's a corkscrew or rosary bead appearance as seen on the right-hand side. The esophageal manometry shows high amplitude esophageal contractions with intermittent aperistaltic contractions. What do you think is the diagnosis? So the likely diagnosis in this case is diffuse esophageal spasms. If the symptoms such as chest pain or dysphagia responds to nitroglycerin, please consider this as the diagnosis. Dysphagia in this case may respond to calcium channel blocker or botulinum toxin injection. So scleroderma is the most common connective tissue disorder involving the esophagus. In fact, 80% of scleroderma patients will have esophageal involvement. There are reduced to absent peristaltic contractions that causes the esophageal dysphagia. It is associated with progressive, not intermittent, dysphagia to both solids and liquids. Since it is associated with low LS pressure, it causes severe GERD, and therefore PPI in this case is the primary treatment. So let's recap dysphagia since it's a high-yield topic on your board exams. There are two types of dysphagia. For oropharyngeal dysphagia, always consider a modified barium swallow. For esophageal dysphagia, consider a classic barium swallow, also called barium esophagram, and an upper endoscopy for patients with solid dysphagia. If motility disorder is being considered, consider a high-resolution esophageal manometry. So thank you for spending your day with me discussing a high-yield topic in internal medicine. You can join our community online to stay updated on high-yield topics on internal medicine for USMLE and NBME exams. You can follow us on Instagram or subscribe to our YouTube channel. Thank you. Take care.